webinar is being recorded, and that recording and the slide presentation that you're going to be seeing today will be posted to our vh.medicaid.ohio.gov website, and it's going to be under the Provider Overview drop-down option. With that, I want to introduce our speakers for the day. First of all, I'd like to introduce our two cabinet directors, my boss, Maureen Corcoran, the director of the Ohio Department of Medicaid, and our wonderful colleague, Director Lori Chris of the Ohio Department of Mental Health and Addiction Services. Then they will in turn introduce the other colleagues from the staff who will be presenting. So directors, I will turn the floor over to you now.
Thank you, Mary. Good morning, and thank you all very much for taking this time. We have a full 2 hours. Hopefully we won't take all the time, but we also want to make sure we have. So here is the agenda for our session today. We're going to go over the state budget issues as well as updates on some of the other core content and areas that we've been working on together with you, and as well as us, obviously, with our departments. You can see those listed there. We'll give you an update on the managed care procurement, and then we want to talk with you about input on several of these next key issues that we're going to be working on. Before we get into a little bit about
they cannot hear.
We're having difficulty with the sound. Having a problem.
They have to use their computer audio to hear. There's no dial-in number or anything.
Did you hear a sound when you went on?
I can hear sound out there.
Oh, you can?
Yeah, the sound's there.
Oh, okay.
They have to use their computer
Okay, so
audio.
make that announcement.
Sure. She said, can you join?
They're on it like a 50%. So everything, if they heard it.
Okay, so they are able to hear you. Part of the, okay, they said they can hear fine, so you can go ahead and pick up.
Okay. We're also trying some new technology, so apparently it is very, very sensitive technology. So I ask everybody in the room to please just don't move, don't breathe, don't type, no noise. Okay. Thank you. We do appreciate your continuing feedback through this. So before we get into it, though, I want to just start with a reflection that I was talking yesterday with one of our staff who had a young boy, 11-year-old boy, is a friend of theirs who committed suicide, and it was sort of, a sucker punch to the stomach, but it reminds us why the work that we do is so important. So while today is about, I think, and I know Lori and I share this, we have a lot of really amazing things to report about and a lot of good news. But it is important that we remember why we do this work, and it's so important to individuals and families and communities across this state. So the final budget that was adopted by the General Assembly really captures a great deal, almost the totality of the priorities that the governor had identified in the areas that Lori and I work with you and interact with you. You also know that we've been doing a lot of work over the last 6 months on some of the current operational considerations, and so we're going to update you on those things as well. Some of the changes that have been kind of the operational priorities for our work are shown here on the slide in front of you. Again, to review for those of you who maybe haven't been in every one of our conversations, to increase access to substance use and mental health treatment, to stabilize the provider network and continue to work out some of the bugs from the behavioral health redesign, to begin flexibility to support access, as well as to address workforce capacity considerations. We're talking today about adjusting some of the payment rates for behavioral health services and some new billing codes, and then to update you and set the stage not only for the work ahead of us, but also for what we expect will be a dynamic input process and working with you to get your feedback. Before we do that, though, I do want to take just a moment and ask for your patience. I want to recognize the many Department of Medicaid staff who have been working in these efforts for. Some of them are known publicly to some of you, and some of them you've probably never heard of. But Agbi Ademan, Steve Alexander, Sir Patrick Beatty, Allison Conklin, Ada Cottrell, Shauna Deems, Al Dickerson, Craig Figge, Megan Grove, Mary Heller, Joel Lodge, Lynn Lyon, Ed Ortopin, Tommy Potter, Megan Powell, Amy Raymond, Roxanne Richardson, Joan Schlagheck, Phoebe Schwamberger, Peggy Smith, Nicole Small, Matt Sturmer, Steve Voigt, Sarah Bomer, Sherry Warner, Lawrence Yawn, and Sarah Zelinsky. And I say that by way of just assuring you the depth and breadth of commitment and great number of hours and passion that all of these folks have brought to our work. And I know that there is a companion group at the Department of Mental Health who have also been putting a great deal of their energy and time into this. I know that many of you also probably participated yesterday in Director Chris's budget testimony, or budget presentation. So we're not going to be reviewing those things, but you know, I'm sure that Lori will kind of connect some of those dots for us where those are important. Certainly on this work we're talking about, she'll be adding, helping me with this presentation as well. So this presentation today, this discussion, is not intended to be a thorough technical briefing. We have materials that we'll be pointing out to you, but we have tried to add enough technical detail so that many of you who have been working with us will know exactly what we're talking about, even though you may be left with some, you know, more fine-tuned specific questions. So we tried, in other words, to find kind of the right balance or the right level so that you would know and understand specifically what we're telling you, but not so detailed that people like Lori and I would not be helpful or useful in that conversation. So the first thing we're going to do is Joan Schlagheck is going to help me. We're going to give you an update on a number of changes that are being made as a result of our conversations around the BH Fix-It, for those of you that know that kind of terminology or reference. So a number of the items that have been identified through our discussions over the last 6 months and by the various stakeholder groups and associations, we've been reviewing and analyzing. And so today is to report to you about the first wave of those things that we will be implementing. So Joan, I'm going to turn it over to you.
Thank you, Director. All right, to start off then, to look at the rate adjustments, the first category of rate adjustments is going to be for the crisis services. And these are select services provided when a patient is experiencing the crisis. So the first one, kind of easy to see, crisis for psychotherapy. That's not only 90839 and 90840, but also 90832 has the KX modifier option. So keep in mind it will apply there as well. Move the microphone a little bit closer so hopefully everyone can hear now. I was just going through the crisis psychotherapy codes that will be seeing a rate increase, as well as 2 of the H codes when using the KX modifier also would have the rate increase. We won't have specifics right here in the webinar. By the end of the day today, we will have our manual posted. It has all of the rate increases included in there. Also for your reference, at the end of the slide deck is a table of all the code tables from the manual that will have updates for you. So it'll be a quick reference. I believe it's about 14 different code charts from the manual have updated rates that you will have that available. Like I said, by the end of the day, we'll have that. So the next category to talk about the rate increases are for the group services. And here we have a number of different codes, as you might expect, for group psychotherapy, including the multifamily, group psychotherapy, TBS day treatment, both the hourly and the per diem, the TBS group, the SUD group services, as well as the nursing group services for both the mental health and the SUD side. So all of those, again, will be updated in the provider manual. The third category of rate increases is not going to apply across the board, but to select group of rendering practitioners. For the advanced practice nurses, for the physician assistants, you will see increases for the evaluation and management codes, the diagnostic assessment codes, both with and without medical. They will all be increased up to what we refer to as 100% of the Medicaid maximum. They will be getting the same rate that the physicians are getting for those same codes. To show you an example of some of the tables that are updated, the first one is group psychotherapy 90853. I want to point out the column headings because the first 5 columns had been in place in the manual. We've added the column on the right to say the rate effective for dates of service August 1 will be the rates in that column. So keep that in mind as you look through the manual later today. The next example has to do with, this is the group counseling for SUD. Again, look at the column headings. We have the rate increase effective August 1, and then going down by the various practitioners that can render it. So a couple of other changes wanted to point out to all of you. The first one being for therapeutic behavioral services, all practitioners will be able to render this service going forward August 1. We are making a change in the Ohio Administrative Code. That rule number is there for your reference. As far as assertive community treatment for ACT, we are removing the physician face-to-face requirement with the recipient every month. That can be a team planning, consultation service, and so forth, but no longer would have to meet every month with the recipient. And then the final one on this list is the chemical dependency counselors who are duly enrolled. They have a second specialty enrolled in MIDS, will be able to render TBS when they've enrolled as the QMHS. So let me show you one more rate chart from the manual. So on this one, a couple of changes on this table that were done. First of all, you'll see on the left-hand side the expanded list of practitioners who can render the service. But as I mentioned earlier, one of the first things we talked about was changing the rates for crisis. You'll see the last column now has a heading, rate with the KX modifier only. So when TBS with KX is rendered, you use the last column to determine the rate. If it's not the crisis, you use the second column from the right for the rate. All right, just a couple of other smaller items that we wanted to bring to everyone's attention. The first one on this page refers to services provided in the hospital emergency rooms. This isn't actually a change in any of the places of service that are in the BH manual, but we are modifying the rule in order to make it more consistent with the language that's already in the manual. So this is not a change that you will see in the manual, but like I said, administrative code update to clarify what has been in place all along. The second one As many of you are already familiar, RN services always require the ordering practitioner to be on the claim. We went back and looked at the nursing scope of practice, and there are some instances where they do not need that order. So the configuration for this is actually going to make it optional for you to put the ordering practitioner on a claim for any RN service. It will be up to you to have the documentation to say what the service was, whether it needed the order or not. And of course, if it is one of those nursing services that require the order, we would expect that to be on the claim. The next one, smoking cessation codes have been added, will be added August 1 for both the mental health and the SUD agencies. Those are two different codes, so the specifications will be in the manual. And then the last one is adding coverage for pregnancy testing. This is a lab code, so there will have to be some CLIA certification with your agency or with a practitioner in your agency, but this will be available on both the mental health and SUD side.
Before we leave those, I want to just add a couple things. As Joan said, so when we think about the nursing scope of practice, please, go back and review that, and as well as your policies. There's, I think, in the scope, in the statute, there's 6 types of categories of activities that a nurse has included in her scope of practice. One requires a prescription from a physician or DO. So, that's the distinction here is for those 5 areas, those will now no longer have to have a prescription of physician order in order to bill for it. But obviously, because the law requires a prescription for that 6th category, you will be responsible for that and make sure that you have your agency policies and documentation in line to accomplish that.
This is Lynn Lyon, and I'm just going to walk through at a high level kind of the next steps with all of the changes that we just walked through to the payment rates as well as the policy changes that are effective August 1st. There are a few regulatory steps that we have to take here. So the first thing that you will see soon is the governor will be signing an executive order, and this allows us to implement these changes August 1st. So immediately following that, we will begin with what you're more familiar with, which is our typical or permanent rule filing process, where we'll have a full public process. So sometime in August, you'll expect to see these rule changes, the administrative rule changes in a clearance process where we'll gather feedback. And then we follow that with the official filing of the rule where there's another opportunity for public comment as well as a public hearing. So those will occur in September and October to implement these changes. A little bit of an extra step that we take here. And also we'll have to get approval from for a state plan amendment for a number of people. That will be happening simultaneously with our submission to CMS will need to be by the scene. So it's very important with all of these opportunities for public process that you do review the rules, and we encourage you to submit feedback through any of those steps of the process. And then on the, so that's kind of the regulatory side. I'm sure you also understand we've been working hard on the technical side to make sure both MIDS as well as the managed care plan claims payment systems are updated and able to accept these changes and process with the new rates. So all that work has been ongoing. On the MIDS side, our system will be ready to pay the new rates, process the new process claims under the new policies on August 2nd. So the policies are effective August 1st. MIDS will be updated as of August 2nd. So there is a 1-day delay there on the MIDS side, but the policies are effective August 1st. We are meeting with all the managed care plans and have been for some time to make sure their systems are ready. And the managed care plans will communicate as necessary on any details of their individual plan systems, but across all of the plans, the changes are all effective August 1st.
So any services provided on August 1st will be reimbursed. Just please, for future service, don't send us your claim until August 2nd. And that's the point of the August 2. But all services on or after August 1 will be covered. While folks are sending in questions and folks are looking at, I want to just say a few other things by way of context, and then we'll be here are kind of gathering up the questions and comments that we're getting from you typed in. So let us just say a little bit about what our thought process was in how we approached this. So first of all, and I know I received a number of questions over the last couple of months, and I know Lori did as well. Please notice that with all these rate changes, there are no decreases in any rates. There are no decreases. These are all increases. Now, what we tried to do was to identify areas where we could very quickly get some immediate help or relief put into the system. So you'll see some things as you're looking through these and thinking about them that may not make, you may have different thoughts about. You can just kind of look at it with the understanding that, there still is other work we need and want to do, but where we thought it would take either more extensive programming changes or would be a more significant conversation with CMS or things that would just take longer, we didn't make those the highest priority for this first piece of work. So we were looking for what may not be at the most refined strategies in some cases, but we were looking for the easiest way to provide immediate stability quickly. Now, it's important in saying that we know we will have to make changes in some of these down the road. So we will be monitoring them, we'll be looking at and analyzing the information. Again, our thought being just get some changes out there quickly, then we'll monitor the response and the different changes that are occurring in the practice patterns, and we'll make adjustments as needed going forward. So just kind of keep that in mind as you're looking at the package of these changes. That was really our goal. Maureen, you want to add to that?
No, I do want to, I guess I'll add that we appreciated the consistent feedback and the consistent opportunity from all of our partners in the community to make sure we truly understood what the challenges were and what the most meaningful areas of change we could make in this first level. And we made every effort to listen to that, and then just great appreciation for the level of work that the Department of Medicaid dove into data analysis and truly understanding not just what the issues were, but what the correct fixes were for those issues. That's my strategy for all parties.
I should also just mention, I know we've gotten this question from some of you, but the reason why it was important for us to wait for the budget to be passed and why it is August 1st instead of July 1st is because of the budget delay. And we did put these rate changes into our conference committee updates so that we could secure the fairly significant additional funding that goes into this. Okay, are we getting questions that we need to address? Angie, Mary?
Yeah, I don't know the best way of doing this. We're still working through the technology, but one question is, can APRN also deliver TBS?
Okay, so the question, in case you couldn't hear it, will an APRN be able to render TBS? You'll see when the manual was posted this afternoon that MDs, DOs, APRNs, independently licensed practitioners, dependently licensed practitioners have all been added to render TBS, both on the individual side as well as group. And you'll see the rates will be included in there as well.
And will pregnancy tests be reimbursed prior to August 1?
The effective date of the pregnancy tests is going to be August 1 going forward. That's going to be set up in fee-for-service. Now, managed care plans have always been able to go above and beyond what fee-for-service has done, so I can't speak as to whether managed care plans have been covering that service to date. That is a question you would have to take to the specific plans to get covered.
So all plans then would be covering it after August 1.
Absolutely. Everyone will be doing it going forward. The question is, some may have been doing it prior to August 1. We don't have that information here with us today.
Okay. The next question is, will these changes apply to outpatient hospital and clinics?
Question is whether these changes are going to be the same for the outpatient behavioral health services, and yes, they are. All of the changes that we've talked about, the rate increases, the practitioners rendering services, the codes, all will apply to the outpatient behavioral health package as well as the community behavioral health agencies.
Next question is, where can folks find a list of all of the rate changes?
Where can you find a list of the rate changes? The manual will be posted later this afternoon. We have sent it through numerous review to be sure we have everything correct. It will be posted today. So that has all of the rate changes as well as the new codes incorporated into it.
Okay. And where can the folks find all of the rule changes?
So the rule changes, they'll be in kind of two batches here. So the first thing that you'll see on August 1st, you'll see the emergency rules posted, and we'll make sure that there's either a link to or to tell you where to find those effective August 1st. And then you will see the permanent versions of the rules through our clearance process. And those will also be available through our website, and we'll make sure through the behavioral health communication streams that we have, the links are all available to those.
So there were a couple other questions that came in that we're going to go back through and try to capture and get some responses to. We've had to change our laptops up, so we'll keep working on those if folks want to continue with the rest of the presentation.
Just one other thing, I did see one question real quickly. There was a question on the RN nursing order. This provider system was configured to always require the physician order for RN services, and would they be okay going forward? Absolutely, there won't be any problems if you have an ordering practitioner on each and every RN claim. It's for just those that want that flexibility. It will be built into the system.
Additional questions that have come in, these folks are sorting through. We'll keep going with the presentation so we can adequately address the questions. So I think now we'd like to shift to give you some updates on some of the work that's been underway. I think everyone knows that we've had a group known as the BH Task Force that Director Chris and I have been convening about every 2 to 3 weeks since the first January. A lot of hard work by the staff of mental health, addiction services, as well as Medicaid that I mentioned earlier. We've been giving that group a very detailed report with glide paths and charts and a variety of other additional information, but we wanted to provide this entire group in this webinar with a brief overview of where things stand.
So we've been working over the past 6 months on, it's been 6 months?
Yes.
On working in earnest to bring more stability to the payments system for BH providers in the managed care space. And that's involved a lot of systems work, a lot of data work. We provided a lot of focus on areas addressing claims payment challenges for providers, providing technical assistance with rapid response teams assigned to help out providers that were having difficulty with billing. Working extensively with the managed care plans to understand how it is that they set their systems up and to modify them where needed to accommodate differences in the BH space for billing for services rather than a clinical model. We address transition requirements for the managed care organizations, and we served as a conduit for provider and association feedback to the managed care plans to identify areas for improvement, including areas such as staffing. Part of the work most recently has been to address recovery or repayment of provider advance payments. That work is ongoing. We have reached out to and connected with 173 providers who have received advance payments, and we have begun working with each provider individually to identify their capacity to make repayment and to identify what the repayment plan might look like for each individual provider. In order to do that, we've had to draw on the provider's data and financial data that we use to sort of inform what a repayment plan might look like in terms of monthly payments or quarterly payments. So that work is going on. We have, during all of that 6-month period, as you have just heard, we've announced rate changes, coverage policy changes. That work began in earnest about 3 months ago and was done sort of in the background. At the same time, the folks were trying to bring stabilization to the system. We've released a urine drug screening guidance on laboratory. The UDS guidance, we began requiring the managed care plans to follow the new urine drug screening guidelines effective July 1 for services delivered to managed care enrollees. Some of the managed care plans have chosen to be less restrictive than the guidelines. We have received some questions around the guidelines, and we want to reiterate that the guidelines are just that. They are not rules, they're guidelines. They're based on clinical standards and were produced by a clinical work group. We will release FAQ as needed in the future based upon any ongoing questions that individuals may have. So the policy is that when the managed care plan is contracted with an SUD treatment provider, provider type 95, that is also enrolled with ODM as an appropriately credentialed laboratory and meets the Medicaid provider eligibility requirements, the managed care plan is directed to accept the laboratory into their panel to allow continuity of care. ODM and the managed care plans have updated the systems to allow SUD treatment providers with a CLIA certified laboratory to bill for those services using their provider type 95 NPI. The laboratory codes can be billed in alignment with the lab's CLIA certification model. And we're going to, in the slides, we provide a link where you can find additional information on that. There have been updates to the Medicaid managed care provider agreement. We have extended behavioral health redesign transition of care patient protection requirements, both for Medicaid managed care and for my care plans. We have revised the prompt pay standards for behavioral health claims for Medicaid managed care. Effective July 1 of 2019, the plans must pay 90% of the claims within 15 days. We've revised the notification requirements for denied, pending, and or suspended claims, both for Medicaid managed care and for my care, to be effective January 1 of 2020. And we've provided clarification that all managed care plans accept claims for behavioral health services for 365 calendar days from the date of service. So we also have some additional managed care updates for you. We have submitted a third-party liability state plan amendment to provide less restriction on third-party payment, third-party payer situations. The TPL state plan amendment has been approved to ensure that access to services is not impeded. We will be developing over the coming months policy and procedures related to implementation of the new state plan. And the changes will not actually be effective until the administrative code is enacted. We are also updating the provider screening rule requirements relating to the following behavioral health practitioners working at Ohio MHAS certified agencies. Those will be practitioners licensed or certified by the Ohio Counselor, Social Worker, and Marriage Family Therapist Board, the Ohio Chemical Dependency Professionals Board, and individuals certified by Ohio MHAS as peer recovery supporters. We're providing for less restriction on the provider screening for these provider types, and should have those in place late fall.
Well, again, while we're getting questions in, I want to particularly thank you, Patrick, for the TPL work. He was amazingly persistent and creative, trying to find some way to make this work. So we really appreciate that.
I'd like to add that these additional policy changes are an acknowledgement not just of the need to increase rates for workforce and capacity, but also to decrease the administrative complexity that providers and plans have been experiencing in creating smooth, efficient processes for clinical pathways to be excellent and reimbursement to be easier. And so really appreciate all of the feedback on how we can accomplish that, and then the attentiveness by both our teams at MHAS and ODM to looking at how to put that into action as well.
What questions do we have, Angie?
Okay, we have a few related to managed care and then a few follow-up for Joan. The first is does the 365 days for managed care plans to accept claims for BH services include claims from outpatient hospitals?
Yes.
Okay.
So the question was, can you repeat the question one more time?
Yes, sorry about that.
Making sure. So
Does the 365 days for managed care plans to accept claims apply to outpatient hospitals?
So
I think we have. Yes, does the 365-day requirement for accepting claims include outpatient hospital? I think we need, we will have to.
I'm looking it up right now. I think it's specific to 84s and 95s, but I will look up the provider agreement.
We're looking that up right now.
Okay, we'll clarify that. Okay. Other questions?
Yes, one moment. Oh, there is a thank you for the advocacy. So we did get a positive comment coming through.
There's a thank you for the advocacy. We appreciate that.
Yeah.
I've gotten a few texts from people. Thank you for your texts and your words of encouragement.
Yeah. Is the PowerPoint from the May 29th stakeholder meeting posted on the website?
It is. It's posted at the bh.medicaid.ohio.gov site.
So the question is the PowerPoint from the May stakeholder meeting available on the website? And the answer is yes. It's available at
bh.medicaid.ohio.gov.
Okay.
Other questions?
Yeah, this one I think Joan would be able to handle here. Wait, I just lost it. I think I heard that a CDCA will be allowed to enroll as a QMHS. Is that correct?
So the question is whether a CDCA, Chemical Dependency Counselor Assistant, would be able to enroll as a QMHS. they have always been able to add that second specialty in their MITS enrollment. The change that will be coming August 1 is that practitioner will be able to render TBS on the mental health side.
So will the CDCA also enroll as a CMS? Is that also a possibility?
CDCA can add the second specialty of a care management specialist. Those are services, both of those practitioners would be providing services on the SUD side. So there's no change. They have been able to enroll with both of those specialties all along.
Okay. And then they asked for a clarification on the TBS chart related to the KX modifier only column.
So the TBS chart, and there's an excerpt here, and you'll see the full one when the manual's posted this afternoon. The column headings are really important to note what rate applies. The TBS has, refer to it as your normal everyday rate in one column. When you are rendering TBS in a crisis situation and you utilize the KX modifier, that is the column on the far right-hand side that you would use to know what rates to expect to be paid.
And can you bill TBS on the phone now, or is CPST the only care coordination service that can be billed via phone?
TBS, according to the administrative code, I'm going on memory here, but I'm fairly certain it has to be a face-to-face service. So CPST would be the only one available with a phone.
Okay.
So we have looked up the answer to the question. The question was, does the requirement for accepting claims 365 days from the date of service apply to outpatient hospital? The terms of the provider agreement state the following: the MCP shall accept claims for BH services described in OAC Chapter 5160-27 for 365 calendar days from the date of service. And so that would not include outpatient hospital.
And before we shift into the new work, I would just say that all of what we just talked with you about will be continuing work in progress. So we'll be talking further with the association about how to have some ongoing technical surveillance and continue the more detailed work as we go forward. But now we're going to shift for the rest of our time into some of the newer issues. Lori, anything you want to say before we do that?
Yeah, so I'd just like to add that when thinking about the Department of Mental Health and Addiction Services budget and other resources that we have available to us, we have tremendous opportunities to support the full development of crisis care for people with mental illness and substance use disorders, for adults and for children. And so thinking about how to best do that work in our communities with the technical assistance and support that we can offer through our department in connection with the resources available through the Department of Medicaid is going to be a really critical approach to the work, and one that we're taking seriously as we develop the budget and now as we implement. The other thing that was easy to hear as the presentation so far this morning has come through is that there are a lot of opportunities for workforce development and to support excellence in clinical services that we can plan together as two departments, but also with all of you in the community in terms of really looking at the ASAM criteria, pursuing what it means to have the full continuum of care available and operating, excellence in urine drug screening processes, and working with the clinical guidance that we've developed in Ohio and national opportunities as well. Building out a full response to smoking cessation, because we know people with mental illness and substance use disorders smoke at higher rates and have more devastating physical health care impacts and higher cost utilization because of that. So we have an opportunity now with this new rate and code to do more work around preparing the workforce for that work. And then also excellence in group counseling, making sure that this is a vital service that all of the citizens of Ohio who are engaged in services rely on, And most providers are engaged in heavily, and we have an opportunity to expand excellence in that with the great opportunities created here today. So looking forward to all of that work.
Yeah, that's an excellent summary. And I also want to just kind of underscore the smoking cessation. We haven't talked as much about that in the past, but I do think your point is really important, Lori, about the higher incidence and utilization in these individuals that we serve with these services. Okay, we're going to start then into some discussion about the our 1115 waiver for substance use disorders. And I want to review with you on the first slide, for those of you that participated in the May 29th stakeholder meeting, when we asked you the question, what did you view as the most important reasons? Here is what you told us. Now, I jokingly reminded you at the time we shouldn't have given people the option for all of the above, only because it makes it a little too easy. But I think the rest of it is still really instructive nonetheless. The fact that all of these areas have been identified as priorities among the remainder of those completing the survey, and it gives us a good idea of some of the key things that we're going to be paying attention to. So Lynn is going to take us through a little bit more of the detail. First, I want to talk to you both Lori and I want to talk to you just a little bit about kind of reminding us about the challenge and the opportunity. So the challenge, as you probably recall from our earlier discussion, in 2018, CMS approached Ohio Medicaid about some issues with our payment model related to substance use residential services. And at the time, there was some varying perspectives about that and some skepticism about it, or skepticism about how it might have been presented to us in different discussions. We have since that time been engaged in discussion with CMS, and in fact, they have strongly encouraged us to pursue the waiver as a way of ensuring continued financial participation for individuals receiving Medicaid services in a residential treatment option. So through that process, then, we had taken a little bit of a pause to evaluate all of this and determine for ourselves and to work with the governor and the governor's staff to apprise them of the situation. And so we have, as we mentioned in the 29th webinar in May, that we've begun then again the work around this. So we're going to give you just a little bit of an update on it. The ultimate opportunity here, which really is terrific for us, is to improve access and quality of services and to rebalance or review our residential and community service capacity. The first, I think, the most important thing to say is that we'll be, first priority will be to undertake an assessment of all the services throughout the state. There won't be any penalty, there won't be any gotcha with any of that, and because of the waiver, it gives us a degree of time out or time to be able to look at these questions without any threat or fear of losing reimbursement. So we'll be doing then this assessment as the first piece of work. Obviously, very important to the waiver is a whole continuum of treatment for substance use disorder, and certainly the continued role of residential treatment is essential in that.
So we've gotten questions from a number of people over the past several months about residential treatment capacity specifically, and know that in the past several years, given the demand for an environmental response to substance use disorders, particularly because of the increased risk of overdose, death, and the deadly nature of opioids, many providers have expanded capacity for residential treatment and done so in the context of direction from the state. And so just want to make sure that we are able to be as clear as possible about what that means today in the context of this waiver. It's important to know that the waiver allows ODM to buy residential treatment in volumes greater than 16 beds, and that's the point of the waiver itself from CMS's standpoint. At the same time, it expects Ohio to have a full continuum of services so that our treatment and engagement and recovery opportunities are not just residential or institutional in nature, but are also community-based as well. And so we're taking both of those obligations and responsibilities very seriously. We also know that the waiver is a 5-year opportunity, and while there is an opportunity to apply for a renewal at the end, we will be changing administrations and at the federal level, or have some changes in congressional makeup. And so we always have to be mindful of what is available to us today, what we intend and hope to have available to us in the future, but the nature that that could change. So we're approaching it with that in mind as well. As Maureen said, we will be doing an assessment of residential capacity. And what that means is that it's a look at each residential operation individually, really trying to understand what's treatment, what's medically necessary, what's housing, and collaborate for a strategy that supports a full continuum of residential, outpatient, and housing opportunities and other environmental strategies to support people in their SVD needs and their recovery. So as of today, and we'll be continuing this work with all of you in partnership, we're encouraging all providers to just stay the course with your residential treatment capacity. I know some of you have asked specific questions about downsizing or upsizing, and we're happy to have those conversations individually without a blanket remark to the whole system. So stay the course, let's actively engage together in this assessment, and we'll take on individual questions as we move forward over the coming weeks and months.
That's very helpful, Lori. And I think just to tag on to that, we know that this issue associated with IMD also has implications for some mental health residential programs for adults, as well as behavioral health residential services for children. So while the waiver will be focused on substance use disorder, we'll be using this opportunity to assess the full range of service issues that we have, both substance use as well as mental health and kids. And you'll see as we talk later about Family First that there's some other avenues in which services for children will also be changing. So, we'll use it as an opportunity. There won't be any dramatic or any kind of upset to any of these services, but we're taking a holistic view and a holistic approach to it. So Lynn is going to talk a little bit more about what has changed from some of the earlier conversations late last year about the waiver and where we stand today, as well as give you a little bit of an update on where we stand process-wise from our discussions with CMS.
Okay, so on the slide that's on the screen here, you'll see just a visual that lays out some of the areas that we're focusing on now as we're meeting with CMS. And we talk to CMS about every 2 weeks. So this is a very intensive process to go through an 1115 approval with CMS. But the areas that you will see some refinement in our final version have to do with these items. So first, around prior authorization, we are going to be not making any immediate changes to prior authorization, but we are going to continue to gather data on lengths of stay, the ASAM levels, looking at repeat episodes of care, and really using that data to inform our ultimate utilization management approach, and to make sure that that also aligns with mental health parity. And then we will be working with the managed care plans to make sure that there is uniformity across utilization management for these services.
So there will not be prior authorization on day one.
And then the next area, which we have some slides, I think, after this topic, so I won't talk a lot here, but around care coordination. As many of you know, that is part of this waiver, the care coordination piece. And we are kind of refreshing and relooking at data and policies around care coordination, but want to make sure that we allow ourselves enough flexibility in our agreement with CMS around this waiver to really be able to implement care coordination to meet the needs of different subpopulations who will be impacted. We also are looking at the medication assisted treatment, or the MAT policy. And I think also, as many of you know, this is a requirement for the waiver that there is plan access to MAT. And with our agreement with CMS, again, we want to make sure that we allow ourselves the maximum amount of time to work with providers to make the necessary system changes to assure access. And then we also, the next item here is, and I think the Director Chris spoke to this a little bit, but talking about the site visits, that we, want to make sure as we're developing our policy around site visits, that these site visits are really used as technical assistance, and for us to be able to work with providers on, levels of care, staffing, treatment capacity. And Medicaid is, of course, working in partnership with mental health and addiction services, licensure, and certification staff to make sure that where we can coordinate on-site activities, that we are thinking about that. So there's definitely some work that we'll be doing there. A couple of new items that were not in the original submission that were proposed also as part of the Medicaid's budget. One is around Medicaid eligibility extension for 12 months for postpartum women. This will be added as a future amendment. So we're working with CMS and working through some of these more, kind of technical changes to things that we have already proposed, where this is really a new policy, new item that we're talking to CMS about. So you will see that, but you will see that in a future amendment to this waiver. And then lastly, related to the SUD residential services, we are also looking at a benefit for mothers and their infants. So the mom and baby dyad service that we have talked about, we have begun talking with CMS about that. We're looking at, options and how that can be implemented and under what Medicaid authority. So it may live in this waiver, it may not, but we are still working on that. So just wanted to kind of call that out, that you'll also be hearing more about that. So hopefully through all these comments you've gathered, one of the things that we really want to make sure that we do as we go through this is to engage with stakeholders. So all of these things that we have already talked about are areas where we want to make sure that we've gathered appropriate stakeholder feedback. So things, like program standards, provider qualifications, the on-site review process itself, our MAT policy, and any other content areas, we want to make sure we're going through a process to gather feedback. So at this time, we realize that, those are different topic areas that may require different participants in a stakeholder discussion. So we are envisioning a focus group type of process to gather feedback. Those are examples of some of the areas. There may be others, or we may combine some of them, but just to kind of give you an idea of what we're thinking. So we would really want to have a focus group of people who are subject matter experts in those different areas, but of course would leave the process open for everyone to be informed and have an opportunity to kind of hear the conversations and feedback that we're receiving. So one of the things that will come after this webinar is a survey that will go out for individuals to provide some feedback on this process that we'll be pursuing for the implementation of the 1115 waiver.
So just, I think, to kind of recognize that, the behavioral health community is a big and broad and deep community. And so the dilemma that we have is always, how do we make sure that there is opportunity to really have meaningful dialogue, but at the same time, we don't want to do it in a way that is exclusive. So, what Lynn has laid out to you is our thinking at this point is to use slightly smaller, more focused group kind of dialogue around key issues. However, unlike how this may have been approached in the past, we would endeavor to have the focus group conversations be open public meetings where people could come and listen, but we would have then maybe around a central table, a smaller group of individuals so that there could actually be more of a back and forth. And obviously what we're trying to get away from is just relying exclusively on big, 200, 300, 400 person meetings or webinars where we're just talking and there really isn't any opportunity for dialogue. So what both Director Chris and I, as well as we know, the governor would want to take away from this is we're going to keep struggling with how to really create opportunity for meaningful dialogue in this process, but not in a fashion that is closed. And so specifically with regard to the 1115 waiver, there is an implementation plan that is required as a part of this. And so we will be using that implementation plan, if you will, as kind of our first vehicle to get input from stakeholders. And this is the process in which we're thinking about doing that. So, any concerns or suggestions, please give us that feedback on the survey. Okay, any questions to those issues, Angie?
Yes. When will the on-site review process begin?
The question is, when will the on-site review process begin? I don't think that we're ready to share dates yet. We have a team that is putting together a pretty detailed project plan with some dates, so as soon as we can share that, we will.
Okay. Will the department be doing anything to assess the quality of the residential treatment facilities or in the future considering requiring certifications such as the ASAM level of care certification for residential treatment?
So the question, that was a big question.
You don't need to repeat.
Okay, so the question was about, will we be looking at quality? Will we be using ASAM certification standards? So I think those are all exactly the areas that we will be working with in our focus groups on the program standards, the quality standards, the levels of care. So, that is exactly what we'll be working on over the coming weeks and months.
Okay. If residential SUD treatment comes under a waiver, another one just came in. Sorry. If residential SUD treatment comes under a waiver, can the Medicaid rate be inclusive of room and board a portion of costs?
So the question there is whether or not Medicaid can reimburse for room and board, and the answer to that is still no.
Thank you very much, Lynn. And, it's always dangerous to try to predict what CMS is going to do, but we don't expect that this will take a long time to get it wrapped up. Again, I'm really right out on the limb here, but we're thinking within the next month or two, it'll be wrapped up, and then we'll be able to move into the more specific discussions about timeframes and the assessment and all the other components of work that we've mentioned. Okay, I want to shift now into a little bit of an update on care coordination, and then we're going to ease our way into a little bit more about the behavioral health components of the Medicaid budget. So first, I want to just kind of frame that, what we're thinking about, what we're working on is how to approach care coordination for those children, youth, and adults who have either or both mental health or a drug addiction issue. So we're trying to be mindful of the entire population of consideration and recognize that particularly with the SUD waiver, we might be taking certain strategies or approaches with those who have a substance use disorder. But what is important to us and upon kind of coming into these roles, both Director Chris and I wanted to kind of step back and make sure that we were in fact thinking comprehensively about children, adults, and all aspects of behavioral health. So we are revisiting the model. As we've mentioned before, we are focused on how to identify those individuals with the greatest need and with a high priority on working to engage those who are difficult to engage or who are not as connected to services, not as easily identified and able to be reached out to. We are doing right now quite a bit of data work in order to look at both the utilization and the potential subpopulations and how to marry that or examine that with various care coordination strategies. Again, this is a place that we commit to you. We will be engaging in more significant discussion and input with you. Still are, as I mentioned, doing quite a bit of specific data analysis. You can see then here, this gives you just an overview of the work that is underway. And you can see there it's really very thoughtful and detailed, looking at a census tract level, looking obviously at things like consumer patterns, including diagnosis, bringing a little bit more to the forefront issues associated with social determinants of health. Obviously paying attention particularly to the extent that we are, as you know, we are utilizing that federal authority for health home. So looking at the physical health and integrated care around physical health conditions, as well as those who have comorbid mental health and substance use disorders. And looking also then at a variety of geographic or locational considerations. And we also are using this as an opportunity to move into a little bit more organized data exchange with other state agencies, not only because of the substance use waiver and the behavioral health care coordination, but now I want to move just a little bit, so stay tuned specifically around the behavioral health care coordination updates. But now I want to move a little bit into how this relates to some of the other work, including items in the budget. So on the next slide, you'll see that, and we'll mention a little bit more in a minute about the specific focus in the budget on the high need multi-system youth and their families. So the priority is to move away from us individually approaching children with complex needs in a bit more of a silo fashion and moving into more of an integrated fashion. Obviously, given the dynamics and demographics of Ohio, it's going to require not only intensive work at the state level, but also at the local and county level to acknowledge and to build on the role and responsibilities that other local and county level entities have also for some of these children. So we'll be building on the work of Family and Children First Councils, and of course continuing and strengthening the collaboration across state agencies. And again, as Lori mentioned earlier, sort of generally, we'll be looking for opportunities to raise funding, not only Medicaid, but other funding sources that are out there. You know, you've seen this, you are well aware of this. Just a few of the driving forces that we're acutely aware of is an increase in the number of youth that are coming into custody, particularly because of the addiction of their parents. The Family First Services Prevention and Services Act, or FFPSA, that will really dramatically change the financing of child welfare in Ohio and across the country. Changes that we are seeing in the out-of-state residential placement, particularly for certain types of multi-system kids who are very complex and specialized needs. And certainly the priority of the governor, not only for children and children's behavioral health generally, but specifically for these complex and multi-system kids. So the focus then, next slide, is to look at a comprehensive system of care for these youth, and working with our partner entities and agencies, both OMAS and us, working with our other partner agencies at the state level with kid responsibility, education, DYS, DOD, et cetera, and focusing on those children and their families who have the most complex needs. We are working right now, again, with some of our data work to identify the types of services and demographics, conditions, diagnoses that are more typical with this group of children, and exploring some of the kinds of Medicaid vehicles or technical approaches that might be necessary or helpful to try to bring a more comprehensive benefit package to bear. So such as, is it a waiver? Is it a different kind of federal Medicaid authority? Things like that. And we will be working again with Family and Children First, as well as with all the child welfare reforms, to have multi-system policy work groups where these issues can be explored in a little bit more detail. It's important, you're probably going to get tired of me talking about the FFPSA, but I think that it is very, very important for those of us in the behavioral health and in the Medicaid and in the other local OMAS and county funding. We have to keep this front and center in our minds. And it really, again, goes to what Lori said earlier about grading funding. With this change in the child welfare financing, it is a total revamping of Title 4E and the priority and uses of 4E funding. It will create some terrific opportunities for expanded flexibility, putting more of an emphasis on preventing kids having to go into child welfare custody. It will enable us to look at different kinds of services that should be utilized, but all of that presents a danger of cost shifting in ways that are not intended. And so our priority, our commitment that Lori and I both made to our child welfare counterparts is, and this, I should mention, this is being guided by Directors Council, both Director Chris and I, with Director Hall at JFS and other state directors, department directors who have an interface with this, to be sure that we keep a focus on that, really this comprehensive and cross-cutting set of implications from this law. And certainly, as you can see here on a couple of the other standards, and it ties right back both to some of your questions, as well as our discussion about the SUD residential, is that at the crux of this for child welfare is the issue of appropriate utilization of congregate residential treatment and pressure or policy emphasis from the federal level to try to reduce that to the greatest extent possible, not to eliminate it, but to reduce it and to put more emphasis on expanding foster home and therapeutic foster home kinds of living arrangements for these kids. So this Qualified Residential Treatment Program, or QRTP, is a new set of requirements that will apply to any residential treatment program that is serving these children and receiving any Title 4E funding. Any Title 4E funding, including Title 4E funding paying for the room and board, would invoke or envelop these requirements. So you can see here what a few of those requirements are, and we'll be taking that into account as we begin to think about some of the other residential and licensure and compliance kind of work that we'll be doing.
So, I think, one of the things that it's probably helpful for all of you to hear is that we recognize the complexity of the regulatory changes that are happening at the federal level, that impact the state level, and the interconnectedness of the work that we're doing in behavioral health and at the Department of Medicaid and Jobs and Family Services to increase access and capacity in community-based care and residential care for kids and families. And the lens that we're using is to make sure that all of our organizations are working collectively to keep the focus on the kids and the families, and not just the least restrictive environment for them, but for all of the providers trying to serve them too, right? Creating these opportunities for maximum effort and quality care and administrative and regulatory environments that support that, and our efforts are focused on that.
Just to tie this a little bit together, we put this kind of under the category of rebalancing our community services capacity. So particularly when we think about more restrictive kinds of treatment environments for kids in custody, there's a few elements of our conversation that we want to just kind of bring together by way of a summary. So the psychiatric residential treatment facility, or PRTF, is technically a hospital level of care, and we are looking at that. We don't currently have that in Ohio. A number of 22 other states do have that specific type of provider categorization. So we are looking at that for Ohio Medicaid, and particularly to be able to meet some of the kinds of very complex needs that these out-of-state providers are providing to our kids. So not every child who goes out of state has an unusual or very specific type of need, but there certainly are some very clear patterns of clustering where there are entities outside of Ohio that can provide services that we can't provide here. So we're looking at that. We'll also be looking at doing some work with the Department of Developmental Disabilities as well. You'll know we've had some conversation. There was some work done in the prior administration to also be sure that in developing more of a behavioral health intensive residential or inpatient hospital-like service, that we're looking also at a companion or an overlapping intensive residential service for children who have a developmental delay as well as a significant behavioral health needs. We've begun meeting with Director Davis and his team. They're very much committed as well to these kids' issues, and we'll be working collaboratively with them. Finally, and we'll take a few questions then, just to summarize. So Director Cornyn, as you know, is the governor's chief policy person for children across the cabinet. So we've been working with her and we'll continue to work with her. There are a number of budget priority initiatives, both in Lori's budget, my budget, as well as a variety of other budgets. So for those of you that follow the kids things, please keep your eyes peeled for some budget summaries that capture all of that. So we mentioned Family and Children First, and Director Sarah LaTourette, who will be shepherding that work both with Director Cornyn and with Director Chris in particular. Christy Burry, who was brought on as the Children's Services Transformation Director within the Department of Job and Family Services, and Marissa's been doing quite a bit of work with Christy on the child welfare work, as well as with Leanne around the broader set of issues for children and visiting. And there is, as you probably know, significant work groups underway around Family and Children First, and we expect to see those kind of morph a little bit as we get closer to some of these issues that we're touching on today around behavioral health needs. So questions in that area, Angie?
Yeah, so is there a tentative date to launch care coordination?
No, at this moment in time, the question was, is there a tentative date to launch care coordination? At this moment in time, we don't have a date. Frankly, some of it is, and I'm going to talk about this in a minute, is we, just within Medicaid, and I know Lori's is even more complex than ours, we have more than 118 items in the Medicaid budget that we'll be implementing, so we're working feverishly right now to try to both identify everything and then begin to kind of identify what the timeframes, resources, et cetera are. So we will keep you posted about that.
Okay. And then there was a question related to data exchange. Will the data exchange effort include schools? For example, might it gather information on youth with special education needs and or youth showing signs of school failure?
So the question was, would the data exchange efforts also include schools or kids in schools who have significant needs? And the short answer is yes. As you may know, or actually maybe everyone isn't aware, we currently, Medicaid does have a specific initiative set up for data sharing with the Department of Education. You can imagine that merging HIPAA and Part 2 and FERPA is enough to make anybody's head hurt. But I would say to you that it is a commitment of the administration, particularly the Lieutenant Governor and Innovate Ohio, and some work that we're doing, as well as Director Chris is doing with the different data exchange vehicles at the state level. And we're really interested in pushing on all kinds, or any of these various potential data sharing possibilities related to children and getting a better handle on particularly these multi-system kid needs. So question was, previously we had said that the date for BH care coordination go live was 7/2020. That is still our rough target, but as I mentioned, we're going to be kind of refining all of our work here in the next couple of weeks to put some more specific deadlines on things. Okay, terrific. All right, we're going to move then into the, I think the last big chunk, which is to update you on those aspects of the Medicaid budget that interface specifically with behavioral health. This has been a little bit of an unusual budget, as I'm sure many of you have heard. And again, I would give sort of a shout out to all the associations, NAMI, the Ohio Council, OARP, and all the other behavioral health related associations. Paying attention to their guidance throughout this process is just about the only way you could keep up with what was going on. And I learned a lot from them as well. So as I mentioned, we have about 118 different initiatives or requirements of Medicaid in the budget. Medicaid budget, as you can see here, is about $25 billion, $27 billion in 21. Remember that about 90 plus, probably now 92, 93% of all individuals served by Medicaid are in managed care, and now more than 80% of our expenditures, including more than 40% of our nursing facility expenditures, are included in managed care. We're going to give you an update on the procurement in a little bit, but meanwhile, I want to just run through some of the key things in our budget that are particularly of relevance to behavioral health. So first, I'm going to ask Marissa to chime in here. We've been doing quite a bit of work around supporting Ohio's kids and families. Marissa, can you give us just a little bit of an update on home visiting and some of the other key things in that arena?
Sure. As you mentioned, Director, we're just thrilled that all of the initiatives that we proposed in the kids space were successfully funded through the budget. And one of those is receiving a significant amount of work here at the department with a huge cross-agency team. That's our support program for moms and infants that also includes home visiting. We've taken quite a comprehensive look at the services that we at Medicaid and some of our sister agencies are providing to pregnant women who are part of the Medicaid program, as well as their infants soon after birth, and have really put a lot of effort into trying to understand where the gaps in care and gaps in cultural competency are. And so the services that we're designing and we're excited to get stakeholder feedback on within the next couple of months, we hope respond to both the gaps in care and gaps in our ability to connect with people at the health system level. We're also continuing investments in reducing infant mortality in partnership with the managed care plans, and the request for applications for use of the managed care plans and our funds in that space for the grants will be coming out within the next week or so. As Lynn mentioned earlier, we're looking into a mom and baby dyad treatment model to ensure that moms, particularly those with addictions, receive the kind of treatment they deserve and are not judged by the healthcare system. And we hope that this will actually help our child protection system as well.
So building on the previous work that OMAS has done with Men with You around care for moms and babies is a natural component for us to build on in the SUD waiver, as Lynn talked about earlier.
And that's a space where we have learned directly from behavioral health providers who have been participating in the MOMS efforts over the past years to inform our design of what the new program might look like. We at Medicaid are also home to a new custody relinquishment fund, and that's another piece of great advocacy, thanks to advocates who helped to ensure those funds made it through the budget. And we will be working with our sister agencies through the Family and Children First Council to figure out how we want to use those funds in a concerted effort. And we will also be, per legislative requirements, developing a plan around all of the multi-system use requirements of the 131st General Assembly.
So in the same space, there was originally in the budget 2 particular local programs, and those both were funded, but pulled out of our that particular line item. So this fund, the Multi-System Youth Fund, as Marissa said, will be done under a plan through or under the guidance or governance of the Family and Children First Council, that this will be a little bit more targeted at individual kids and families who are in danger of relinquishment when a local community, comes together and brings their resources to bear, but doesn't quite have enough or needs a little bit of additional assistance to prevent the family and the relinquishment from occurring.
And I'd like to appreciate both of our directors here, Director Chris and Director Corcoran, for your commitment to work at the cabinet level on use of that fund and on making sure that we get services for kids who really need them and families who are at risk.
Thank you. Thanks for all of your work, Marissa. I want to give you a little bit of an overview of the pharmacy issues, a couple other areas of our budget. And, I want to kind of echo something that Terry Russell said to me. Part of the changes that you heard earlier in the rate discussions that Joe went over with you were a very explicit and direct attempt on our part to enhance the medical services, the ability of people to get physician, nursing care, and particularly to facilitate, again, with these kind of more targeted initial steps, recognizing the importance of medications in the treatment of individuals with behavioral health needs. So the language, NAMI had a particular amendment that we were able to get in the later stages of the budget, remained in the final budget, that protects or continues the provisions of how psychiatric medications are handled in terms of lesser restrictions on prior authorization and the like. There is also, you probably know, this was probably the hottest topic in our budget. The overall set of issues around our pharmacy program. It is a big deal. It is a lot of money. It affects a lot of people and is, of course, particularly important in this area of behavioral health. So we will be moving to a single preferred drug list, so that the medications will be the same across the different managed care plans. And in so doing, the State Department will be handling all of the rebates, so there won't be, that'll be kind of evening out or removing any differential incentives around drugs, so that we can have a single consistent list of drugs that will be provided through the managed care plans as well as in our fee-for-service program. And then in addition to that, we'll be bringing up a single pharmacy benefit manager. Again, that's been a fairly popular topic in our public policy discussions. So that'll be a significant area that we'll need and want to have more discussion with you. We'll have to go through a procurement for that, of course. In addition, there are a variety of provisions in the budget that require additional transparency, particularly regarding drug prices, and requiring us, Medicaid, to identify drugs for which significant expenditures occur that are outside of what our benchmarking might indicate. This has been done in a couple of states, and calling attention to those as areas for potential renegotiation or additional rebates or cost savings. We're also looking at how to provide additional professional services using pharmacists. In other words, today, pharmacists, as you know, obviously do a lot of work dispensing medications and overseeing that. They do today, as part of our managed care program, they do provide additional services. However, we're also looking at how to provide direct coding and billing for that as a way of encouraging and more specifically incentivizing the professional services that could be provided by pharmacists to our communities. There also is a requirement to create the Drug Transparency and Affordability Council. That will be the responsibility of the Department of Administrative Services. And I think everyone knows, there's a very kind of complex supply chain in the drug industry, as there is with a supply chain in any area of undertaking. Manufacturers, wholesalers, all the way down to the consumer. And so the point of this Affordability Council is to look more broadly at all of the drug purchasing the state government does beyond just the Department of Medicaid, and to look kind of holistically at whether we're doing everything that we can in that area. So this will continue to be an area of significant public concern. Next, I want to just mention briefly, there were 3 areas in the long-term care area. Most of these, as you see on the slide, most of these we will be moving forward to implement. However, the reason I wanted to include it here is that there were 6 or 7 vetoes in our budget that were rolled up into one veto, and it was specifically a policy decision of the administration to veto provisions that had specific rates being put in statute. So I forget, but there was one about paying $5.69 for a certain kind of meal. There was another about a very specific percentage change in reimbursement. So these are still very important areas of work. There was some funding for these in the budget. We'll be continuing to move forward with them, but I wanted to mention them here just so that you understand in that area related to the veto on rates, that those things that were very specifically identified in statute were vetoed for that reason. There was another about vagus nerve stimulation and some hospital rates, just to inform you a little bit about sort of why those were handled that way. I want to just mention a couple of others. More broadly in the transparency area, there's quite a bit in the budget, quite a bit of discussion in the budget, and an executive order that's since been issued around transparency and information related to medical and healthcare costs. In that spirit, we will very soon be releasing a number of Medicaid managed care dashboards that will be identifying a host of clinical measures for our managed care plans, comparing to each other, and ultimately looking more broadly at sort of national standards. There will be some financial dashboards. There are consumer caps or consumer satisfaction dashboards. There's really four or five dashboards that Patrick and our policy team have put together. Those will all be posted soon. And our goal there, again, in the interest of transparency, is to begin to provide a great deal of information that we hope will be useful to enlighten or provide more visibility into our programs. I also want to just mention there was a veto related to the often referred to as the rural workforce. And just to mention about that there is and was and continues to be a great deal of concern generally about the workforce, and a specific recognition and understanding about the importance and difficulty of the workforce issues, particularly in rural areas of Ohio. We felt that this was, for those of you that were kind of noticing this, it was specifically an initiative that would have provided significant funding to several urban metro hospitals. And so, our concern was really that if this is a rural workforce issue, that didn't seem, in our view, to be the appropriate policy approach to that. So that's just a little bit of an update about other areas of our Medicaid budget. Questions on that?
Yeah. Is there a tentative date as to when the single PDL will be implemented? Preferred drug list.
That's a very good question. Is there a date for the single PDL, preferred drug list? We don't have that yet. We do expect to have that shortly. That is a high priority for us. Some of the work and certainly the discussion had already been underway with the managed care plans, but we'll give you a specific date here shortly to nail it down.
Okay. Once a single PBM is procured, will ODM carve the pharmacy benefit out of managed care benefits package?
That's a really good question, and honestly, there's even been some confusion in the newspapers. Question was, will we carve drugs out? So just to kind of review sort of three terminologies: single preferred drug list, PDL, that is really a list of drugs that are identified as the preferred list to be used consistently. Then the single PBM, single pharmacy benefit manager, that is being done in some states as a carve out. It also can be done as a carve in. So even though it may not be administered in the same way through managed care, it can be done as both a fee-for-service approach or a managed care approach. It is our intention to continue that as a managed care strategy. So at this point in time, we haven't done all the procurement yet, but to approach it as continuing medications within the managed care context, but through a single pharmacy benefit management as required by the statute.
Okay. Is there any activity around increasing the role of FQHCs, community hospitals, and home care agencies in delivering behavioral health services?
Yeah, that's a good question. The question is there any effort to increase the role of community hospitals and FQHCs? There were, as you may have noticed, a variety of provisions in the budget that related to FQHCs. Got more to kind of pricing considerations, so there wasn't as much of a focus on some of the service or behavioral health issues specifically. But we appreciate a very good working relationship with the FQHCs. We meet with them and their leadership frequently. We know of their commitment and priority to assist with the behavioral health services, and so we'll be continuing to work with them as well around this whole array of issues that we've been touching on today. Other questions, Angie?
Yeah, so we've been getting a number of billing questions coming in throughout the last hour or so. So we'll try to loop back around, time permitting. So I just wanted to acknowledge that for folks who are emailing or providing that feedback. But we did get a question around what email box folks can use to submit additional billing questions. So they can email those to bh-enroll@medicaid.ohio.gov.
Where, is that on any of our slides? Comment was, is it on this one? That's on the last page, or recite it again for me.
It is bh-enroll@medicaid.ohio.gov.
All right, so I'm going to repeat that. So any, what Angie pointed out is we've been getting a number of specific billing questions. We'll come back to some of those as time permits here in just a couple minutes. We're really getting to the end and appreciate your patience. This is a lot to have covered, particularly by a phone call. So we will come back to those, but any questions in that area can be sent to bh-enroll@medicaid.ohio.gov.
Yep. Yes, thank you.
All right, so we're going to then, any other macro questions? Okay, so we'll come back to some of the billing questions as we're able here. We're going to do then just a brief update on the managed care procurement, and then Director Chris and I will speak to wrap up. And I want to turn it over now to Cassandra Buxton, who is our project manager for the procurement. She does just an amazing job, and I hope that you'll all have an opportunity to meet and talk with her. So Cassandra?
Okay, so one of the things that we wanted to, as far as this procurement, make sure we emphasize is the mission statement. So Jim Tassi and Director Corcoran got together to talk about what is important and what is our primary goal for this procurement. And it's to focus on the individual rather than the business of managed care. And we want to do better for the people that we serve. So you will see this throughout many presentations that we do. You have heard Director Corcoran speak on this, as well as Jim Tassi. And this is something that we want to ensure that we keep in the forefront of everyone's minds. I want to provide some recent updates. Many of you know that we released our first RFI back on June 13th, and we have been receiving in various comments. The one thing that I did want to stress is that as part of this procurement request for information for the initial one, there are various ways in which you can access that RFI. One way is through the Ohio Department of Medicaid homepage. For that specific link, it is on this slide where it is located, and it is under the medicaid.ohio.gov/procurement.
And we are having just a little bit of trouble advancing the slides. So the links are in the slide deck that you'll have available to you, but.
Yes. Okay. You can also email us directly. We do have a managed care procurement mailbox set up. So if you would like to provide feedback, or as you're engaging with individuals receiving services, or if you personally would like to provide feedback, please feel free to email us at mcprocurement@medicaid.ohio.gov. The first RFI is currently scheduled to be open until July 31st. However, we are looking at extending that date. We're going to do some reviews and assessment this week, the level of feedback that we've received thus far, as well as the amount of feedback, and make a determination about extending that. We are also looking at releasing our RFI number 2, which is scheduled to be released later this fall. We do not have a definitive around that, as we want to focus on our stakeholder engagement and receive appropriate input from individuals that we serve. As far as our legislative updates, there are a few things that we want to make sure give us adequate time for public participation and to design a program that meets the needs of the individuals whom we serve. And procurement of a single PBM will be separate but coordinated with the managed care procurement to ensure consistencies. These are all things that you've heard Director Corcoran and others speak about during this discussion. Some of the other things that we wanted to highlight is to give you examples of some of the feedback we've received as well as themes. So around concerns, there's nothing surprising here that I'm going to cover. These are things that we are already focused on as part of the procurement, but we are receiving this information. There's an administrative burden, so billing, timely payment, and prior authorization, all things that we've covered during this discussion. Difficulty in getting questions answered by our MCP staff. Denials of prior authorization for addiction treatment. Care coordination for children in rural areas. These are just some of the things that we're seeing thus far. As we continue to receive back, we will assess that feedback, look at it for consideration, and begin to categorize these things. Some of the recommendations that we have also received is increased standardization in billing, credentialing, and medical necessity criteria. Use of a single drug formulary. Note, Ohio is moving to a single preferred drug list, as Director Corcoran spoke about. Care coordination, case management ideas for children in custody, and additional dental coverage. So these are just some of the small things that that we are looking at. There's a much bigger picture that we're going to continue to strive towards, but I ask that as you engage with individuals, if you have ideas, please utilize the RFI that's out there on the ODM webpage, as well as feel free to provide your feedback via our email.
Terrific. Thank you, Cassandra. All right, so we want to just wrap up with a little bit of next steps. You know, I think you've heard us say pretty repeatedly today that we are committed to figuring out ways where we can have meaningful dialogue with stakeholders and with those of you throughout the behavioral health community, and to bring in as much transparency as we can to these various processes, and as well as things like utilization data, dashboards, and the like. In particular, we want to just kind of remind you, or kind of call to the front of your mind, that we continue to ask for your ideas and your guidance about the SUD waiver. We'll be working on the implementation manual as a vehicle for conversation with broadly, care coordination, managed care plan procurement, which Cassandra just updated you on, as well as others of these initiatives that we've touched on.
So the intention is that we'll be soliciting feedback for a survey, and we'll be continuing to create forums, both in larger gatherings where we can provide information, but also in smaller conversations where we can dig deeper into the detail necessary to implement the strategies and plans that are created over the next several months together. We are, as Director Corcoran said, there are a number of departments who are engaged in better serving people with mental illness and addiction, families and children, adults as well. And our effort at the cabinet level is to coordinate all of these activities and to serve one another and you as subject matter experts and participants in committee work across all of these agencies. The goal is to make sure that we've got a coordinated effort and are really listening pragmatically to what families and people need, and then act on that in their best interest and their best interest. And so we'll continue to make that commitment. We appreciate all of the ways that you're contacting us through all of the partnerships you have with a variety of state organizations and employees, and in the forums that we set up as well. We look forward to hearing more from you, how we can serve you better, and are happy to be able to report the progress that we've made to date.
I don't think I could say it any better, so I think that's a great place for us to kind of wrap up our formal comments for today. Let me just check one more time and see if there's questions. And then again, the slide deck and the manual will be available later today. And there are links, there's all the information connecting you to the different tables where the rate changes are evidenced. So you'll have all of that by the end of the day. Any questions, Angie?
No, just a lot of feedback in terms of the technical difficulty. So just want to remind folks where they can find the slide deck later today.
bh.medicaid.ohio.gov, and it's at the provider overview dropdown.
So bh.medicaid.ohio.gov/provider/overview.
Okay.
And again, apologies for some of the technical difficulties. We will keep working on this till we get it right, but appreciate everybody's patience.
And Cassandra, could you repeat how they can fit or provide some feedback related to managed care procurement?
Sure, it's at MC Procurement, all one word, at medicaid.ohio.gov.
Okay. And then I think folks should be able to see then the link to where the information can be found as well.
Yes.
So hopefully folks are able to see that.
I think that brings us to the end of our time, and again, thank you all for not only what you do to make a difference and hopefully to continue to we will make progress in these areas, but for your patience and committing your time to do this today. So thank you. Okay, that's it.